This is a video in clinical medicine from the New England Journal of Medicine.
Female urethral catheterization, the insertion of a catheter through the urethra into the urinary bladder to permit drainage of urine, is a fundamental skill for the practicing healthcare professional. This video discusses the indications for catheterization, the equipment available, the current methods of catheter insertion and maintenance, potential complications, and how to troubleshoot common problems. Female urethral catheterization is indicated for both therapeutic and diagnostic purposes. Urinary catheterization is therapeutic in several circumstances. It permits effective bladder drainage in patients with acute or chronic urinary retention. A urinary catheter may be used to instill medication for local intravesical therapy. Urethral catheterization and irrigation may be used to remove blood and clots from the urinary bladder in patients with gross hematuria. Urethral catheterization facilitates diagnosis in several circumstances, such as obtaining sterile urine specimens for urinalysis or culture, measuring post-void residual volumes, and monitoring urinary output during surgery or in critically ill patients. Catheterization also allows installation of contrast media during various imaging procedures, such as voiding cystourethography and retrograde urethography. Suspected or confirmed urethral injury can be a contraindication to catheterization. Urethral injuries are rare and are most commonly a result of pelvic fractures or multisystem injuries. If blood is found at the urethral meatus, or if there is evidence of gross hematuria or a perineal hematoma, then urethral or bladder neck injury should be considered. If there is any question of injury, both genital and rectal exams should be performed, and retrograde urethography considered before catheterization is attempted. In this setting, consultation with a specialist prior to catheterization, if feasible and if time permits, is prudent. Patients who are unable to cooperate may require extra time for calming or may even need sedation for the procedure. Consultation with a urologist should be considered in patients with a recent history of urethral or bladder surgery. Since urinary catheterization can cause infection or trauma, this technique should not be used for routine management of urinary incontinence, but should be reserved for circumstances in which non-invasive methods fail. A variety of prepackaged urethral catheterization kits are commercially available. A typical kit includes a water-absorbent underpad, a sterile fenestrated drape, sterile gloves, 4 or 5 swabs, forceps, an antiseptic solution, a 10 cc syringe pre-filled with lubricating jelly, a 10 cc syringe pre-filled with sterile water for balloon inflation, a pre-connected closed Foley system, and a specimen container with cap and label. Other items, such as those for securing the system to the patient or the bed, may need to be gathered separately. There are many types of catheters varying in construction material, design, and size. Catheters are most often made from latex. However, the use of silicone catheters is becoming more widespread, as latex hypersensitivity and even anaphylaxis related to latex are increasingly recognized. Silver alloy hydrogel-coated latex catheters may decrease bacterial colonization and growth and should be considered for patients with recurrent infections. The Foley catheter is most frequently used in female patients requiring an indwelling catheter. It is a double-lumen, straight-tip catheter with a balloon at its end that is inflated after insertion into the bladder to help retain the position of the catheter. Other types of catheters include the triple-lumen catheter, which can be used for continuous bladder irrigation after bladder surgery or for patients requiring irrigation to prevent retention of clots within the bladder, and the straight catheter, which may be used for intermittent catheterization or on a one-time basis to obtain a urine sample. The size of the catheter is categorized most frequently in French units, circumference in millimeters. The narrowest and softest tube that can effectively be used is recommended, thereby limiting discomfort and decreasing the risk of infection. Smaller catheters are used for narrow urethras or in patients with a history of strictures or scarring. 14 French to 16 French catheters are appropriate for most adult women. Larger catheters, 18 to 24 French, may be used in patients who are at risk for obstruction of the lumen, for example, patients with gross hematuria with clots. Explain the procedure to the patient, addressing any specific questions or concerns. Possible complications such as urethral and bladder trauma, bleeding, and infection should be discussed. With the bed flat, the patient should lie supine in a lithotomy position or a frog-legged position with legs apart and feet together. If available, a table with stirrups may be used to facilitate visualization. Begin by inspecting the genital area to identify the urethral meatus. The adult female urethral meatus, typically 5 to 6 millimeters in diameter, is an ovoid opening with the long axis on the vertical. The female urethra is a fibromuscular tube that is approximately 3.5 to 4 centimeters long. It is located below the clitoris and above the vaginal orifice in the superior fornix of the vulva. Inspect the sterile catheterization kit. Remove it from its outer packaging and place it within reach. Open the inner paper wrapping to form a sterile field. To reduce the risk of infection, urethral catheterization should be performed under sterile conditions, which include wearing sterile gloves when handling the equipment and throughout the procedure. To avoid contaminating the sterile gloves, once you have washed your hands carefully, retrieve the absorbent pad from the top of the kit and place it with the plastic side down beneath the patient's buttocks before putting on the sterile gloves. If pad placement is difficult, re-wash your hands before putting on sterile gloves and proceeding. Then, cover the patient's abdomen and superior pubic region with the fenestrated drape. Now, with the patient draped, organize the contents of the tray on the sterile field. Pour the antiseptic solution over the preparation swabs in the tray compartment. Set aside 1 or 2 of the swabs, in case excess antiseptic solution needs to be blotted. Squeeze some sterile catheter lubricant onto the tray or into the sterile field to lubricate the catheter tip before inserting it into the urethra. After preparing the tray, using your non-dominant hand, identify the urethra by spreading the labia majora and minora, by placing the thumb and index finger medial to the inner labia, spreading the finger slightly, and with gentle traction, pulling upward toward the head of the patient. This hand is no longer sterile. Do not release this non-sterile hand from this position. After you identify the urethral meatus, use an expanding circular motion to clean the opening with the remaining prep swabs. Lubricate the distal end of the catheter with the sterile jelly. Though lubrication is necessary, too much lubricant may delay the flow of urine. Holding the catheter in the dominant hand, gently introduce the catheter tip into the meatus and slowly advance it through the urethra into the bladder. If the catheter is accidentally inserted into the vagina, or if the tip is contaminated, discard it and obtain a new sterile catheter before proceeding. Because the female urethra is short, urine may begin to flow before the balloon has completely entered the bladder. Once you can see urine flowing through the catheter, continue to advance the catheter for another 3 to 5 centimeters to ensure the complete insertion of the balloon in the bladder. You may feel resistance before the catheter is fully inserted in the bladder at the external sphincter. Instruct the patient to breathe deeply and to relax, which should facilitate passage of the catheter into the bladder. Never force the catheter through the urethra, as this may cause urethral trauma or perforation. Insert the catheter completely into the urethra and do not inflate the balloon until there is return of urine in order to avoid trauma due to intraurethral inflation. Inject the entire 10 cc syringe of sterile water to inflate the 5 cc balloon completely. Note that the labeled volume of the balloon does not indicate the higher volume required to fill it properly. Partially filled balloons may lead to catheter displacement and urethral or bladder trauma. Saline should not be used because it may cause crystallization and valve malfunction. Air also should not be used because it allows the balloon to float in the bladder, possibly kinking the catheter. With the balloon completely inflated, pull gently on the catheter to fix the balloon against the bladder wall. Secure the catheter to the medial thigh of the patient with tape or a catheter securing device. Finally, place the drainage bag in a convenient location below the level of the bladder. To remove an indwelling catheter equipped with a balloon, first deflate the balloon completely, ensuring that all of the previously injected water is retrieved. After that, gently pull out the catheter. If there is difficulty in removing the catheter, consultation with a specialist is advised. The most common complications of urethral catheterization are trauma and infection. Trauma may result from incorrect insertion of the catheter into the urethra or removal of the catheter with the balloon inflated. Strictures, narrowing, and scarring of the urethra may result from such traumatic injury and can make catheterization difficult. Infection is common in patients with indwelling catheters. Within 48 hours, up to 85% of catheters may be colonized with bacteria, which may lead to bacteriuria. The best way to prevent complications is to avoid catheterization whenever possible. Continue to review the patient's need for an indwelling catheter and remove it as soon as possible. The urethra of some female patients may be difficult to catheterize for various reasons that include previous operative procedures, obesity, previous childbirth, and anatomical variants of pelvic organs. Catheterization may also be difficult in patients for whom positioning may be limited, such as those with chronic arthritis. If you are unable to pass the catheter through the urethra, or if you encounter resistance, the urethra may be kinked because of pelvic organ prolapse. If the prolapse is large and protrudes from the vaginal opening, it may be necessary to reduce it by gently applying pressure to the prolapse and guiding it back into the vagina. If the urethra is not easily visualized, place the index finger of your non-sterile hand inside the vaginal orifice and gently apply pressure superiorly, both to straighten the urethra and to allow the finger to serve as a guide into the superior urethral opening. If you feel the catheter beside the finger, it is incorrectly placed inside the vagina. In this case, the catheter should be removed and properly discarded. Use a new sterile catheter and attempt catheterization again. In morbidly obese patients, an assistant is often necessary to aid in retraction and to maintain sterility. If the flow of urine is slow or non-existent, the catheter may be obstructed or in the wrong site, or the bladder may be empty. Flush the catheter with saline. If saline or urine freely returns, the catheter is properly inserted. Massaging the bladder by gently pressing on the patient's abdomen may also facilitate the free flow of urine. Female urethral catheterization performed with proper sterile technique is an invaluable, reliable method for both therapeutic and diagnostic purposes. It is important for all practicing health professionals to master the proper insertion technique and understand the risks and benefits of the procedure.